Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balata from Roots Community Health Center, reporting for the week of March 6, 2023. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Today, I'm going to start with variant proportions. XBB.1.5 is now almost at 90% of projected variants in the United States, and it's the only variant that is currently increasing. All of the other variants, which are all Omicron subvariants, seem to be decreasing. And we've got just a little bit, about 8% of the BQ1 and the BQ11. And everything else is pretty much under 1% of the total. So we know that XBB.1.5 is very, very contagious. We're still hearing of outbreaks and super spreader events and certainly new cases. So far, it does not appear to be making people any sicker than the other subvariants. And so we've really been essentially contending with Omicron and all of its subvariants for over a year now, and we haven't evolved any new Greek alphabet letters, so that's a good thing so far. But we can see that XBB.1.5 is almost completely taken over in the Northeast area, and it is certainly on the rise across the country. And barring anything new, it does look poised to take over across the country. Unfortunately, we did hear reports of a recent outbreak in the Northeast, in the Cape Cod area of Massachusetts. This was a nursing home outbreak that has sickened over 90 people, and it has left at least 5 residents dead. And this is certainly chilling news to be seeing here, well, anytime, but especially now in 2023. I think this brings back terrible memories of 2020 and kind of how it all got started in this country. And the fact that we're seeing this now in 2023, 2 months ahead of the end of the federal public health emergency, is definitely raising some questions. On Friday, we received notice that California, Washington, and Oregon will all plan to lift mask requirements in high-risk settings. So this is definitely concerning timing, if nothing else, that on April 3rd, there will no longer be masks required in hospitals, in prisons, in shelters. And so we're definitely concerned because we know that there's still quite a bit of COVID circulating and that these settings are called high risk for a reason. So we definitely don't want to be going backwards. And we'd like to maintain the gains that we have accomplished so far, but certainly seeing a nursing home outbreak like this and hoping that we will continue to hear about these things at least. But certainly to have 5 deaths in one facility is a tragedy. And I'm just concerned that this might not be the last time that we hear about such a tragedy. I say this without knowing details about, for example, whether these nursing home residents were able to receive any outpatient treatment. But one of the things that I wanted to share, at least from early on in our experience or earlier on in the pandemic, when it comes to the skilled nursing facilities, and this includes those located within our prisons, when the monoclonal antibody treatments became available, those were like a godsend. Skilled nursing facilities have the right staffing and the right equipment to administer monoclonal antibodies. And many of our elders and others who live in skilled nursing facilities were able to safely receive this life-saving treatment of monoclonal antibodies. And from my perspective, and I know many of us working in this field, this was a real game changer at the time, really kind of second to only to the vaccines. But sadly, as I've been talking about for the last couple of months here, we lost all of our monoclonal antibody treatments. And because they're not able to neutralize that XBB.1.5 or the BQ subvariants. So this is a tool that we just lost, and that was really helpful for some of our most vulnerable populations. So it's really unfortunate. I haven't heard any news about any kind of like Operation Warp Speed for monoclonal antibodies, but I firmly believe that we really need one. These are not cheap things to make, but they are doable. And we can make them if there is support to make them. It's just that the drug companies need to be supported in doing so, and without the government investments that they've been making so far, we just won't have that tool. And even though we know that Paxlovid is a great treatment, I've been mentioning it pretty much every week for quite a while now, it does have some situations where it's either difficult to administer or where it can't be administered, and actually not being able to swallow pills is one of them. And so we just want to kind of flag that COVID is not over. It's still circulating quite a bit. Masks among staff in high-risk facilities will reduce the risk of transmission. And when we have lost tools that we need to treat, especially the most vulnerable, we are still very much in a situation where we are not out of the woods yet. We're still losing people. And in fact, if we look at deaths in the United States, we're currently at 364 average daily confirmed deaths. This equates to about 2,500 deaths per week in the United States alone. So far in 2023, we've already lost almost 29,000 people to SARS-CoV-2, and we're still only in early March. So these are still very high and very devastating numbers. And it does not seem like a good time to start removing protections for the most vulnerable. And so we are certainly going to be advocating for maintaining masking in high-risk settings like in hospitals. And if you agree with that, there are some suggestions there in the post of reaching out to leadership to make your voice heard on this point. If we continue at the rate that we're at now, so that's like if things don't get worse, although that's a concern I have, as I just mentioned, removing masks in facilities where things can transmit quickly, it seems like a good recipe for more outbreaks and more super spreaders. But even if things just continue where we are now, we're still talking about 130,000 to 150,000 deaths per year. And this is only the deaths that are directly related to the initial or the acute COVID infection. So this doesn't include the post-COVID events that we're seeing. It's very clear, it's been replicated now more than once, that we are seeing heart attacks and strokes in the post-COVID period. Also, long COVID is leading to deaths from various causes. And so the numbers that I'm giving you are just from the acute COVID. I did want to mention here, though, that according to a recent article in Becker's Hospital Review, soon death certificates will include an option for long COVID complications or post-COVID events as a possibility to select, so that we can really track this, because right now these are not things that we can actually put on the death certificate. You either died immediately from the COVID, or COVID was a contributing cause of death in the acute period of time. But if it's been more than 30 days, it's not an option currently, but we're hearing that soon this will be an option, and this will be really helpful so that those who have to certify death certificates, which is the responsibility of the treating physician or potentially the primary care physician, depending on where the patient died. But we can now, or soon, we will be able to include the possibility of the long-term complications of COVID-19. And I think this will be very helpful in terms of getting an accurate accounting of COVID-19 related deaths. And I think it will help us to get a better grasp of the impact of post-COVID and long COVID deaths. So overall, I think this is an important development, and we'll be waiting for more details on that. Unfortunately, not a whole lot is improving as it relates to hospitalization. There's still a fair bit of COVID-related hospitalization going on here in the United States. This is still highest in the 60 and up age group, followed by the 0 to 17 age group. This should give us all pause. As I reported last week, we are unfortunately seeing young people, little ones being hospitalized with COVID-19. And most of these hospitalizations are vaccine preventable hospitalizations. Remember that about half of children who are hospitalized for COVID-19, about half of them do not have an underlying condition. So it's not about vaccinating only children who have an underlying condition, because half of those children who are hospitalized for COVID don't have any underlying condition. And we can prevent much of this hospitalization with the vaccines. And we have very low vaccination rates across the board in children. The half that do have an underlying condition, if you're under 2 years old, the most common underlying condition is being born premature. And for those from 2 to 17 years of age, the most common underlying condition is asthma. So these are both really common. And so the take-home message here is that there is no reason to expose children to a potential hospitalization or poor outcome, especially when we can prevent all of this with the vaccine. Vaccination rates are way too low if we want to spare our babies from severe illness, hospitalization, or even death. We really need to be doing better with vaccination in young people. Here in Alameda County, we are up from 95 people in the hospital last week to 113 people this week. 11 of those are in the ICU. Looking at our wastewater data, we can see, unfortunately, it's just continuing to head straight up. This data is a little more than a week old, but we're going to continue to look at wastewater, since this is the one area where I think we are better off now than we were before the pandemic. And that is that it seems like we've built a fair bit of infrastructure and some new reporting lines around wastewater. And we're learning more and more in this area. And I remain hopeful that this will be a useful tool going forward. For now, we're just looking at the direction it's going. It's heading up, and we are watching to see how this correlates with increasing cases. And this is sort of against the backdrop that we know about, which is that case data itself is less and less reliable. Sadly, the Johns Hopkins tracker that was established early on in the pandemic is going to be retired this Friday, March 10th. And this is kind of a sad state of affairs, but it really represents what we've been saying here each week, which is that case data is becoming less and less reliable. And the Johns Hopkins folks cited the fact that with people testing at home, case data is no longer a great indicator. But they also indicated that hospital and death data from the federal government's Health and Human Services is a good source of data that we can be looking to. But as we know, that's late. By the time we see hospitalizations and deaths going up, that means we've already experienced the increase in cases. So it's too late to do anything about, except for monitor hospital capacity. And that's important for the delivery system, but it doesn't really tell us much about how much COVID is in our environment and whether we need to be doing anything differently as far as our behavior goes. So unfortunately, we are mostly looking at the late indicators of hospitalization and death. We're hoping that wastewater is going to help us ascertain where we are. And we'll continue to report out on cases and case positivity whenever it seems useful, or like if we're seeing a big change. Right now in Alameda County, cases are relatively flat and the overall number of tests being done is decreasing. So we will just continue to watch and see if there's anything of interest to report. I'm going to briefly touch on norovirus. We can see here that wastewater concentration continues to go up here locally and in many places across the country. We really only see hospitalization from norovirus, mostly in the extremes of age, our babies and our elders, for dehydration. So just please wash your hands and don't prepare food for others if you have a stomach bug. Sanitize your high touch surfaces. with a bleach or peroxide-based cleaner. Alcohol does not work. Hand sanitizers do not work. So you're going to need to wash those hands with soap and water. And if you're a loved one, your loved one contracts this, you're vomiting and diarrhea for a few days, we're just really wanting to ensure that you don't become dehydrated. And so that is really the only real warning sign. Other than that, it's just contagious and gross. So we want to try to avoid it. And definitely want to avoid it in your workplace, in your classroom, in your restaurant, and so on. So I've been getting a couple of questions lately I'm just going to try to touch on. So the first one is COVID endemic now? And I'm going to do my best to address this question, kind of acknowledging the fact that there isn't like a number or a cutoff or really a hard and fast definition. The definition of endemic really centers around whether the disease is predictable and manageable. And even though an endemic can definitely involve ups and downs like the flu, we'll generally know what's in store, kind of when we're going to see a wave, how big it will likely be, and so forth. With COVID so far, we've had surges literally in every season. We've had spring, we have had early summer, we've had late summer, we've had fall, we have early winter, we have late winter. So there's not a predictable pattern just yet. I think we're all feeling like this is probably the best we've been so far since everything got started, because we haven't seen a big, huge wave, and our winter wave was definitely less and earlier than we had predicted. And so that's a good thing. But we're also still seeing quite a bit of daily deaths. We're seeing quite a bit of COVID circulation still. And as I've mentioned, we don't really know how our surges are looking because our case data isn't super reliable. But nonetheless, it feels more predictable than it has been. But is it predictable? Well, it's kind of hard to say. Looking forward, we're going to know much better looking back. And so we'll continue to kind of keep an eye on things. I think that what the biggest concern would be is a new variant. I think if we don't get any more variants, if we just stay with XBB.1.5, then hopefully we can feel that we're settling into some kind of predictability soon. And so I think a couple more seasons will probably help a lot of us feel more comfortable being able to feel that we're moving out of a pandemic. But remember that according to the World Health Organization, we are still in a pandemic, a public health emergency of international concern. They reaffirmed this in late January, and that is still the position that we're in. So if we don't see any big waves this summer or next winter, I think a lot of us will just feel comfortable saying we're in an endemic state. It's not a hard and fast definition, but right now it still very much feels like we are in a pandemic because we are sort of waiting to see what is going to happen in the next season or two. And part of the reason for that is because we've just had our Omicron booster campaign essentially done in September. We've not done great in our Omicron booster coverage. So if you haven't gotten your Omicron booster yet, that is definitely something to consider, especially if you have not caught COVID in the last 6 to 9 months. You kind of need that boost. And I think that the protection, as I reviewed 2 weeks ago, the protection from the booster, it stays pretty good for a while, but after, 6 months or so, it's probably starting to wear off. And I'm not talking about just antibodies. I'm talking about protection against hospitalization and death, especially for our most vulnerable. So far, there's no recommendation about getting a booster more than once a year. And right now, it seems like everyone's leaning towards a fall booster each year. But I just have to call out the fact that, again, COVID has not been predictable or particularly seasonal. Although winter tends to be the worst season, we've had waves in every season. So what we're sort of keeping an eye on is, as folks' protection from the Omicron booster starts to wear off, could we start to see a spring or summer surge that folks don't have adequate protection against? So these are just things we're watching and waiting. And because that is a concern, a very real concern of a lot of different experts, and something that folks are going to be watching, That is a good indication that we're not really endemic yet. We're still waiting. We're still a little on the edge of our seat to see kind of where we go next. And we probably need a little more time and experience with this under our belt before I think we'll be comfortable saying it's endemic. I think the other piece of it that I want to say is that saying it's endemic isn't exactly good news when we're losing almost 150,000 people per year. So endemic kind of means this is what we got. This is what we're dealing with. And so it's not necessarily a good or bad thing. It is more trying to do our best to characterize where we are. And we do seem to still be in the pandemic mode. And unfortunately, with these last remaining steps of removing protections, particularly in facilities where outbreaks can definitely occur, hospitals, shelters, prisons, and so on. Definitely hopeful that each of these facilities will maintain masks, because we don't want to be exacerbating a situation. We don't want to be seeing poor outcomes for those folks who are vulnerable within those settings. And so that can certainly contribute to more transmission. So things are continuing to evolve, and we're also removing protection. So those things will also have an impact, at least here in the United States, which, as we have seen, is going to have an impact globally, because we're all very connected. There's quite a bit of travel going on, quite a bit of mixing, still quite a bit of COVID in our environment. So as we're kind of looking forward, I think the biggest thing I'm probably hoping for is something that will reduce transmission. And right now, that is mostly masking, limiting your time, mixing indoors, improving indoor ventilation. But hopefully, we will also see better vaccines that reduce transmission. I think that's what we really need. And part of the concern around ending the public health emergency is, will there be a focus on developing a better vaccine? Will there be a focus on developing monoclonal antibodies to protect especially the most vulnerable among us, and those who can't take Paxlovid, or those who don't mount a response to the vaccine? So by this attempt to sort of move on, we don't want to normalize repeat infection. We know that there's a risk with that. We also don't want to leave folks behind. And unfortunately, that is sort of the situation that we're in today. But I am hopeful that some of these technologies will get a boost of some type of investment from the government, so that we can be in a better position with better vaccines and better treatments as we move forward. The other question I'm getting, which I'm not going to spend a lot of time on because it's not my area of expertise, but I'm just going to touch on it, is questions about whether this is a lab leak or whether this is a bioterrorism weapon. And I think it appears to be fairly safe to say this is not a bioterrorism weapon. There just simply is not, there just isn't the technology or the know-how or the ability to do something like that. In terms of engineering something, that would be some serious sci-fi stuff. And they're pretty much everyone who is in the area of security and bioterrorism and whatnot, I think has concluded high confidence that this is not a bioterrorism weapon. Now, could it be a lab leak or an error or a mishandling? I'm not sure if we're ever going to know the answer to that. I think it's important that we do our due diligence to figure it out, why, so it doesn't happen again. But it doesn't change where we are. It doesn't change the situation that we're currently in. It doesn't mean anything about what we need to do about the current pandemic that we're in. So that's just something I want to underscore, because some of the things I'm hearing about conclusions people are trying to draw from the suspicion that is a lab leak don't make sense. So because it's a lab leak, it doesn't change the fact that we still need to take a vaccine to protect ourselves with it. It doesn't change the fact that if you get sick with it and you're high risk for a bad outcome, you should take treatment. So I will say it matters only in terms of us doing a better job at protecting the world and identifying if something went wrong, what could we do to prevent it? I think there is at this time more evidence for the original theory, which is that it jumped species in a wet market type of a setting. And that is something that we've seen happen with other viruses. And that does seem to be the most likely theory. But either way, the result and what we need to do about it absolutely remains the same. And that is, please do what you can to avoid getting infected or reinfected. Reinfection does seem to have a cumulative type of harm, and we want to prevent obviously spreading it to others as well. Try to gather outside as much as possible, improve your indoor air quality, wear a high quality filtration mask like an N95 or a KN95 or a KF94. Use rapid tests for pre-event testing. If you get exposed or if you have symptoms, repeat your rapid test every day or two while you continue to wear that high filtration mask around others. Or you can go ahead and get that more definitive PCR test, especially if you're someone who should be treated if you are positive. Have a treatment plan. Are you going to take Paxlovid? If there's some reason you can't take Paxlovid, are you going to get remdesivir? Is remdesivir available in your area? Here in Oakland, we're very fortunate to still have our friends at Total Infusion at Eastmont Mall, and they are able to do the remdesivir infusion for now. We're going to have to keep an eye on what is changing with the ending of the emergency, but for now that remains available. Please don't go to work, don't go to school. If you feel sick, don't go exposing others to whatever you've got. Stay home and rest. But if you insist on going out, please wear a well-fitted N95 mask as source control to keep you from sickening or even killing someone else. We also want to make sure that nobody loses their health benefits at this time. If you are a Medicaid recipient, please update your information so that your state Medicaid office will know how to reach you. If you're in California, you can use the link in the post to update your contact information. Please do that now because we know that the disenrollment process is going to begin next month. If you don't have a primary care provider, please get one. Know how to reach them before you need them. Make a treatment plan. Get up to date on your booster. If you have not got an Omicron booster, you really need to get one. If you didn't want the mRNA vaccine, you can go ahead and get a Novavax that is still available at this time. Remember to eat a balanced, nutritious diet. Consider a multivitamin supplement. Consider getting those vitamin D levels checked to see if you need supplementation. Get some regular exercise and get a good night's sleep and manage those stress levels. Go to that primary care doctor to get a regular checkup, get those baseline labs checked, make sure everything is going fine. You don't have diabetes, check that blood pressure, and so on. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.